Hey guys, it's Dr. Conley. Oh my gosh, what a class. I just got through with your last round of discussion boards and it's pretty amazing. I don't recall before having such a large class because there's almost 18 of us and putting out the number of 100% that I did on the grading rubric. It was pretty easy. Click, 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 click. So everything is thoroughly reviewed. You have been reading each other's posts, which is key because what I have to say to the whole class, I put in individual posts. So when you're scanning those, I'm sure as you've seen, I know because I can see that you've seen, I put comments in everybody's post. You read those, and that's basically me talking to you. But it kind of does lead to a nice discussion. At any rate, you guys are all in, and I appreciate that. The harder you work, the harder I work. I'm putting a ton of hours into this course, but that's because I know you guys are as well, and I'm very enthused about that. A couple of points I want to make after going through all that. Try to use the term substance use, as opposed to substance abuse. Abuse, the word implies that there is an appropriate use for something. You can use methamphetamine or you can abuse methamphetamine. Well, there is no use of meth. There's no effective, safe use of which you can then say something has been abused. You can abuse prescription medications because, there's a proper way to take it, but there's no proper way to take heroin. There's no proper way to take ayahuasca, hallucinogens, et cetera, et cetera. So just in general, also the term has been dropped from DSM. There used to be a diagnostic category, substance abuse disorder or issue or whatever. They took it out because it's not, it lacks construct validity. For more on that, see Conley's research. At any rate, we also want to substitute the word motivation and level of motivation for denial. We're trying to get rid of denial. Denial is a river in Egypt. It's a bad old addiction counselor joke. Denial is it implies that somebody knows the truth and they're denying it. Denying is what we do when we're accused of something that we think we didn't do. It's like, do you deny that you, et cetera, et cetera? And you almost take an accusatory term. That's in that word. It's a very powerful little word. It's been around the field of addictions for a long time. We're trying to get rid of it. More contemporary practice says, what's the level of motivation? They're in pre-contemplation. They don't think they have a problem and they don't want to do anything about it. That's a pre-contemplation. Contemplation, I'm thinking about it. Everybody's telling me I have one, but I don't really think that I do. I'm willing to contemplate the idea. But get into that that motivational interviewing paradigm and out of the idea that we're going to confront somebody's denial and bust it. Along with that, and I kind of landed on one of your posts, intervention is not an evidence-based model. The intervention that you see on TV is horrible. Most anything you see that is produced in Hollywood is it's produced to attract commercial sales. They're really going to do anything that they think are going to get eyes on the screen so they can sell products. Be very careful with stuff that is produced in the popular media. At any rate, because intervention is a stupid kind of portrayal of what addiction is like. It's also exploitative and stigmatizing. Whenever you see people with addiction acting it out on TV, it's like, don't do that. This is very personal. I mean, this is people dying. I hate these documentaries of shooting galleries and stuff like that. It's like, isn't that kind of intrusive of their boundaries? These are sick people. They have a mental illness, At any rate, I'm sorry to go on a rave. Stay away from the intervention model. It's not so evidence-based. We really don't want to confront people. By the way, interventions, as I said I wish I could remember whose post, they benefit the family more than they do the person with the disorder because they're setting a boundary, saying you can no longer sit in this house stoned out of your mind, sucking up all our money. Boundary. If you're going to do this and we can't stop you, you're not going to do it here. You're going to have to be someplace else. And that can be very healing for families to get an active addict out of their immediate personal environment because it is really stressful to have someone who's actively addicted in the same room with you all the time, coming home at night, etc. So that was the other one. The third one, so use, not abuse, motivation, not denial, interventions are not evidence-based, the limits of insight and etiology. Give me a second. Insight-oriented psychodynamic psychotherapy is excellent. It's a model that's commonly used with trauma. You form a healing relationship with somebody. You get down to what the root causes are. You go through the past. You work on PTSD, et cetera, et cetera. That's all fine. That's not necessarily going to heal somebody with an addictive disorder. We need to attack the symptoms and get them into remission. I made a point in a reply to somebody, actually on the side, not on the board, that checking my time. I made a point that while a large percentage of people who have suffered trauma adapt to that trauma by seeking solace in substances, while a large percentage of traumatized people develop an SUD, that doesn't mean that the larger percentage of the SUD population was traumatized. There's definitely a connection between trauma and addiction, definitely. But if you look at the overall, it is not the root etiology. It is not always. And getting down to how you became addicted and what went wrong in the first place, it does not liberate somebody. It doesn't work. You need to focus on the current symptoms. You need to focus on people getting into changing their life, working on honesty, et cetera, et cetera. Now, that said, long-term sobriety, and I've done this for a living for years. You guys know I did. Long-term sobriety, somewhere in that first year and into the second year, many people have deep underlying psychodynamic issues. Fine, work it out in therapy. Once the brain is desaturated, once the brain has come back to normal, once they have learned how to find solace and comfort in life, in the absence of activating every damn endocannabinoid receptor in their brain and body, once they have learned how to live life without the ease and comfort of alcohol, once they have stabilized on medication-assisted treatment for their opioid use disorder, I'll come back to that one in a minute, then you can get into therapy. But don't think that you're going to get into psychotherapy with somebody in the first 6 weeks, 8, 10 weeks of recovery, 2 months, 6 months, etc. It takes a while. The frontal cortex is damaged. It's going to have to come back no matter what substance you're using. So at any rate, there's that. And about, I don't know if I didn't teach this or didn't jump up in the book. You guys all fell for this one item on the test. 80% of you got it wrong. I know it tells me what percentage by item. Contingency management is not a big model of treatment for heroin. I mean, should it be for heroin users and opiates? It works to some degree. There's a whole bunch written on it further in your textbook. Search the word contingency in the textbook and it'll jump up in a later section. But opioid and heroin use disorders, the primary method of treatment is medication-assisted treatment. You have to have methadone and or an antagonist. You all got that one. So you have to have an alternate agonist or an antagonist to effectively treat it. So that's my little spiel for you guys. You're doing great. We rocked through a couple of modules, 2 down, 5 to go. I know that there's a fasting holiday coming up for our Jewish colleagues. We take a little bit of a breath here. Watch your deadlines. We're heading into module 3. I'm going to put my eyes on my other screen over here. You've got Caffeine, starring Dr. Conley as a caffeine-intoxicated businessman. Not an easy, difficult role for me to play. With a student, I don't know, 10, 12 years ago. Nicotine and tobacco, oh my gosh, they kill almost 500,000 people a year. It is the big killer. Cannabinoids, I may throw up an additional slideshow on that. I've come up with some really good material on that recently. I'll put it in an announcement. You've got hallucinogens. I'm actually researching hallucinogens right now. No, not that way. I'm researching the evidence base and the scientific base for using hallucinogens as an intervention, and there's a lot of shenanigans in that field. You'll be getting more from me on that. Dissociatives and then inhalants, follow my advice on how to read all that stuff. Don't die on the science, and there's pretty much a little video for me on everything. So at any rate, I'm still under 10 minutes on this video. You guys are rocking it. You're obviously working really hard. I'll end up where I started from. I really appreciate the hard work, and I will match you step for step, word for word, all the way through to the end of the semester. Thanks.